in a SNF, I get called physical therapist, usually daily. They don't understand the difference between occupational therapy and physical therapy. They know that you're there to help them. If I'm going into an eval, I usually stick with occupational therapy, focuses on typical tasks that you do every day. I've been practicing since September of 2021. I passed my boards in August, and I started doing PRN right away. And then I am currently on week 5 of my first travel assignment. So my 2 field works were in inpatient rehab at a hospital, and I did a pediatric setting. I didn't love my pediatric setting, so I kind of knew right away that I wanted to do geriatrics. I was also a rehab tech before doing OT school for 6-7 months or so. So I knew I had that experience going into school that I wanted to do at least a little bit of skilled nursing. With COVID, I wasn't able to do any type of field work in a nursing home. So I knew for sure that I wanted to have some type of experience in that setting. It's been a journey, a heck of a journey so far, that's to say the least. So I'm usually up by like 6:45, 6:30, eat breakfast real quick, and I just kind of go in my scrub. So I usually do some treatments first, and once my boss usually gets in, he does morning meeting at 9 with the other managers on the floor, and then he usually has paperwork for me that comes from the hospital, and it kind of gives me information on like the new evals that come in like over the weekend or late last night. That way I have those for the day. So and then I also kind of see who may need assistance with feeding. So then I kind of plan my day around that too. So if I know like 1 or 2 people, like I need to see them do a feed treatment or self-feeding, then I kind of be like, okay, I'll see them at breakfast or I see them at lunch. And that kind of narrows down my day a little bit. So I usually save my evals for like later just because I don't know everything yet on those people. So that kind of saves time for me. And really another thing about SNF is, productivity. If you haven't heard that word yet, productivity is a big thing in SNF. So you have to kind of watch your time, be pretty quick with what you're doing during the day. And that's why it's important to kind of glance at your paperwork first, know where you're going, and that way you're not wasting time during the day to do all of that. I usually do a chart review before going to see the patient, just to know I have a baseline of what's going on, what's their diagnosis, if they have any therapy notes from the hospital or for wherever they were previous, I like to look through those. So I kind of have a baseline of idea of where they are. So once I go in, I chat with the patient, introduce myself, ask them how they're feeling, what I do, why I'm there. That's a big thing that I have to explain a lot. And then usually first I go into a cognitive assessment just right away, just seeing if they can understand different things, if they know where they are. Both at the PRN place and here, they require the BIMS. I'm not sure if you're familiar with that. It's a cognitive assessment. So you ask the patient if they can repeat 3 words. It's blue, sock, and bed. Those are the ones that we use. And then they repeat them, and then we ask them to remember those 3 words. And then you ask the day, the week, the year, and the month that we're in. And depending on their score, it kind of gives you an idea if they have a mild deficit, moderate deficit, or severe deficit. And then from there, if they're kind of, with it still and able to communicate all of this information, that I go into asking simple questions about their history. So where they live, did they live with anybody? Questions about their home, 1 story, 2 story, any grab bars, in the bathroom, is it safe? How many steps do you have to go in? Just trying to get to know the patient as much as possible, because that's how I write goals, and that's how you'll write goals based on the patient, because that's what they'll need in order to be able to go home. And then I usually move on into my other assessments, bed mobility, sitting edge of bed, balance, And a big one now with COVID is functional activity tolerance, whether if they've had COVID or not. The population can decline rather quickly if they're not like out of bed being active. So looking at their activity tolerance, are they out of breath? What's their O2 after they move, just from getting from supine to sitting? And then if able, can they stand? What's their standing tolerance like? And then do a basic like range of motion test. To be honest, I don't go every range of motion. I do a basic manual muscle test. It's just kind of generic, it's basic, simple, and it's quick. So if they're able to, I like to see toilet transfers, lower body dressing, upper body dressing. So I always ask if they need to go to the bathroom, want to do any type of grooming, hygiene, and I encourage that. And probably the most popular one is a hip kit, whether it's actually for a hip patient or not. Sock aid, reacher, all of that comes in a typical hip kit, is good for a lot of different people, even if they had like a back surgery or, a little bit balance issues. We kind of give those out, especially during ADL sessions. Just free weight dumbbells for strengthening. I do that a lot. And then really simple, just like stacking cones. I use those if we're doing like in-room treatments, kind of put them out for balance, make them reach. And you can also use them for simulating like IADLs, so cleaning, making them go around the room, do different things like that, bending down to the floor. That's kind of like the basic things. I mean, you can also use their things in rooms, so like using their clothes, washcloths, do laundry, and you just have to be a little bit creative sometimes with, depending on COVID and all of that stuff. I would say splints. Using splints has been a big thing at this facility here. A lot of the long-term residents have contractures that we're trying to improve, but obviously we aren't going to be able to fix completely. But they still have the resources that in the previous time they haven't had a whole lot of splints, so they've gotten pretty bad. So we're trying to help correct those as best as we can. But yeah, those are probably like the most popular things I use. On a general basis. So it's a really wide variety. It's a rehab to home. Skilled nursing kind of has that both wings. You have the long-term residents, and you also have people that just come for some quick stays, some longer stays. But really, I think right now, the youngest that we have is 34, and maybe the oldest is up in the 90s. So really wide variety. The two in the 30s, one was a very severe stroke, and the other one was actually a drug overdose, which down here in North Carolina, I've seen a lot more of. So there's some chronic kidney failures, like if it's new, then they take on dialysis. So they come and kind of get that medical management that they need. Lots of injuries from falls, hip replacements, knee replacements, facial, just any type of medical management after a fall usually comes through a SNF. Any post-surgical intervention, so like a colostomy or any type of ostomy that will come through. Encephalopathy is just a generalized diagnosis of just weakness. They might have went to the hospital, they weren't feeling well, friends noticed they weren't getting out of bed, something that kind of triggered them that they needed more care than they were getting like back home. For long-term residents, we usually pick them up to do with wheelchair positioning. It's not an actual diagnosis, but that's kind of the treatment diagnosis that we'll put on. Again, feeding is one, and then nursing can refer to us if they've noticed like a decline in transfers or a decline in getting in and out of bed or getting dressed, like they're just kind of refusing to do that. We'll pick them up, just kind of eval and see what they're doing, see how they're doing, different things like that if we can help. So to be honest, when starting PRN, I was getting burnt out pretty quickly, which is kind of why I jumped into travel. and that's why I wanted to change. I was taking on maybe a little bit too much, doing 3 to 4 different buildings. I mean, with PRN, it's great because you get to bounce around, and I knew the buildings pretty well with being a rehab tech prior with the same company. But you know, it was just a lot, and I realized like I wasn't like really happy doing it. I was happy starting out, but then after a while I was like, okay, I'm getting worn out. Like, it's the same thing every day. Like, I wanted something new. So I would say doing a PRN, starting out, it was a little rough, but right now I feel I have pretty good balance. You know, doing, even though they're fuller days, Monday through Friday, I feel like I have a pretty good balance. You know, like after work, I kind of chill out for a little bit and then try to go to the gym or take a walk. With it being nicer down here in North Carolina, I'm able to get outside a little bit more and kind of force myself to get out. And one thing I've learned by doing travel is that I don't feel like the pressure is on me to like make these people like the best they can. Like, while I want to, you know, it's not a long-term job. Like for me, like as much, if I have a bad day, you know, like I can go home, forget about it, because I know it's not, no, tomorrow's not going to be the same. Like it's okay. Like it's only for 13 weeks too. So even as miserable as I could be, you know, it's not permanent, which I think is really fortunate that we have the opportunity to do that and get to explore different things. So with travel, I would say recently with a patient, he's one of the younger ones, 34 years old, multiple strokes back in like November. So he's been in the hospital ever since then. Recently came to us, and you know, he's just dependent for everything. You know, he's trying to get his range of motion, some muscle tone back, and he's just lost everything. And with him being so young, you want him to progress because he wants to go back home to his kids, wife, and just get back to his daily life. And one day I was working with him specifically on self-feeding, and he lifted his arm for like the very first time and instantly started crying. And like to him, like that was like the world, because he was able to lift it, not even, he couldn't get it to his mouth, but he lifted it like off of his pillow. And to him, like that was like the world. And he was like, wow, like I'm improving. And since then, I think that was maybe 2 weeks ago. And since then, he's just made like progress like day by day. So I think it's really cool to see, like, just, even though it's little progress, you know, it's cool to see just the daily improvements that people can make. For SNF in general, be patient. It takes a lot of patience to be in a SNF, I think, and don't be afraid to ask questions. That's something that I constantly battle with myself, and I'm not one to ask a lot of questions, but starting out, I kind of was thrown into it, and you know, you are forced to ask questions in order to learn and grow as a therapist. You know, unfortunately, we can't learn everything in school. You know, we are there for only a short time. I was in the spring cohort, so that kind of made it a little bit harder, being like a little bit faster paced, especially during that last part of schooling. And with a SNF too, you also have to deal with Medicare, Medicaid, and all types of insurance, which really is just a whole different ball game, because they control everything, honestly. Like, yeah, like a therapist can say, we want them to leave, you know, 2 weeks from now, but Medicare will be like, nope, they're leaving tomorrow. Or an insurance will be like, no, they've met their progress, like they're going home. And it's like they've never even touched the patient or have seen the patient. They're just reading notes and kind of looking at terminology, and they get to dictate what kind of happens. And that's the most frustrating thing, I think, working in a SNF, because your hands are tied when it comes to all of that. So definitely ask questions, because that's going to help you in the long run, because you're not going to learn everything overnight. For travel, I would say, like, you have to be flexible. I'm the only OTR in the building right now, so that is a lot. It's what I signed up for. You know, it happens, and you have to rely on finding a mentor, finding friends that, you know, can help you along the way that are going to be allowing you to grow as a practitioner, because being by yourself, you don't have anybody else to rely on. Like, you are it, which is kind of cool. And the fact that, like, I get to, you know, kind of make all the decisions when it comes to patients like that, but definitely can be stressful in terms too. But I would definitely say if anybody is looking to travel, like, make the leap and jump and go for it, because you can always go back to a full-time or PRN somewhere, because travel is not permanent. It's not a permanent thing. 13 weeks, and I think you can do anything in 13 weeks. So.